to speak about this Lucidis webinar. Yeah. So I'm a consultant of the group ONO, and I will start very quick on EDOF. On EDOF extended depth of focus and the pseudo non-diffractive beams. We start in 2018. I will show you some the outcomes from 2020, the complications that we have, and the conclusion. Just to remember quickly, the EDOF family of IOL is a new method to improve the range of vision without splitting the light ray. And it's creating one elongated focal point. There are currently 3 different types of lenses that can be classified as EDOF IOL, which employ radically different technology. And that's very important to have that in mind, because there are quite confusing system between EDOF and other lenses. Here you have the different EDOF family from the SAV. I will speak about the Mini Well Ready, the Technis Symphony, the Lucidis, and the other one, like the last one, addon, harmonies, or synergy, is a mix of different type. Here is the type that we will speak. We will speak about this Lucidis, which is really astonished for a lens, and the other one very quick. So here you have the aberration, that's a Symphony, and that's a Lucidis. You have to remember the people who do a lot of refractive surgery for presbyopia. You use the 4th order of spherical aberration, and it's exactly one of the EDOF system. And it's interesting to know that what we do on the cornea, we can do on a lens, and you will have an EDOF lenses, which you do an aberration, the spherical aberration number 4, and you have a different type of distance. We use that for a long time with presby LASIK. It's working, I will say, pretty well, but not as well as we want. There is a lot of correction after that. We have to speak with the patient, and there are a lot of blood. That's the first EDOF. The second one is the Symphony. We speak a lot because it's a very big company. And if you see, it's an EDOF which use the system of a diffractive system. And I'm surprised that you don't have too much halo with this type of lens, and you have also an elongated focus with this lens. And now the last one, the Lucidis one, which is totally different and is really an improved system. The main optical property is an aspheric central part of the lens behaving similar to an hexagon. And that's a key system by transmitting a bezel-like ray of light called pseudo non-diffractive beam. And that's really something pretty new. And so that's an EDOF lenses, but with a completely different system. Here, if you see a Gaussian beam on the left, you have a Gaussian beam. And here you have a bezel beam. And this beam will continue all the way long. You will have, thanks to this hexagon, you will have a different type of lens, a bezel lens from here to here. So that's an hexagon, and that's the normal wavelength. Here you have an EDOF, which is always the same from all this part is the same. You have this beam, which is always from here to here the same beam. And that's really the secret of this lens. And it was quite difficult because Max didn't tell us everything. It's normal. It's quite normal. But at the end we understand why this lens is so particular and so good. Here you see on the top you have a Gaussian lens with a spherical aberration. Let's say the fourth spherical aberration that we do, for example, for Presby LASIK. You see the depth of focus is very tiny and the resolution is not so good. When you use this type of lens, the Axicon, you see the depth of focus is so big. And here, all the time it's not blurred. That's really incredible. And that's really a new technology that the only Lucidis and the SAV have done. It's really a good system. And for the people who want to copy it, it's a Swiss patent, it's a worldwide patent. Don't worry, it's well protected and you don't have any problem. So to compare with a multifocal EOL to an EDOF EOL, first of all, it doesn't generate halos. The contrast sensitivity is the normal range, doesn't require neural adaptation. For most daily activity, patient can read without correction, an excellent binocular vision, and the level of acceptance is high. And I think the multifocal or the trifocal are really not the future. Here, if you see all the EDOF system, that's the Lucidis. That's slides from SAV. And you can see that you have lower dysphotopsia, maintain image quality, and it's dependence of the pupillary. But in the day surgery, the people are not very disturbed with this pupillary problem. That's all the lens from SAV, Harmony, addon, Lucidis. We'll speak about Lucidis. The range is the +5 to +30, and you have now the toric correction of the lens, which is quite useful. From +5 to you have the +1 to 4.5. And it's an hydrophilic acrylic with 26% of water content. That's the system who works, the aspheric alignment. And you can see it's very pupillary dependence, but in the real life, I will say that the people are not very disturbed with this system. We have quite better results with the Lucidis in a normal life. I will show you the operation that we do quite daily in our clinics. So we do 2 paracentesis. We put some anesthesia inside the eye. We put the OVD dispersive, and we do a 2.0 incision in a temporal size. And for the Lucidis, we increase to 2.2 at the beginning, and now we succeed with a 2.0. We do a capsulorhexis a little, I do always a little more than 5.0. And I think it's important for the Lucidis to enlarge a little, to have a big, at the beginning, a big capsulorhexis. I do the hydrodissection, hydrodelineation. I use a Stellaris with a Cobra tip. I use a growth of Keiki Metao, and I think it's very useful. I take Nagahara, I do the shop technique. I take out the nucleus, it's not very difficult. And the epinucleus is always a little bit challenging because with this phaco shop is not always going very quickly. And then I use the bimanual irrigation aspiration from Bovet, and that's not a big problem. And I take out the cortex. left hand. And then I will full the entire chamber with Novedi cohesive, and I put a capsule span ring, a tension ring quite all the time because it's fixed my lenses, and I have less rotation for toric lenses. You just have to put that in the bag. And then I introduce the Lucidis inside the chamber. You see, it's 2.2 at this time. And the beginner, you have to not to push too much the lens because it's a strong lenses, and you can have some zonulolies at the beginning. It's something that you have to have respect with this lens. It's quite a good lens. As you can see in the beginning here, you can see this little bubble and this reflection of the lens. It's very important that you center the lens. If you have a problem with the bag, you will have some problem. You see here, it's very important to center the lenses. So let's go next step. We start in 2017 with 40 lenses. And now in 2019, we put 207 lenses. And this year, we were quite not too good with the COVID. We put only 150 lenses, but we are still quite happy with, and I will show you the binocular defocus curve. And it's very interesting. That's our own defocus curve. You see that between plus 1.5, you have 0.6 in decimal, till minus 2, you still have 0.6 in decimal. That's a huge defocus curve. You don't have more than the other lenses doesn't have that. It's really very, very comfortable to work with this lens. It's really incredible. We first do a very quick prospective study in 2018 with my chief director, Anna Ramburu. We take people from more than 50 with a cataract, motivation for spectacle independence, without, at this time, that was without any astigmatism, a range between 22 and 25 millimeters of IOL. We take every problem with the people, and we look at the uncorrected visual acuity from far, intermediate, and near. And we were very, very surprised that near was pretty good. I just show you this first slide. So that was binocular uncorrected visual acuity. You see that non-corrected visual acuity of distance that was in decimal 0.92, 50% was 1.0, 75 was 0.9, and 100% was 0.8. Intermediate was 0.75, and you see that near was 0.8, and we have 100% 0.5. So I feel with the other, when we compare with the other multifocal lenses, that they are very, very good results. We do another retrospective study when Max asked me to do some webinar. So I take the 77 patients that we have done this year. They were 53 female, 24 male, middle age 70, and we have number of Lucidis 154, and we have 28 toric lenses. The results, sorry. The best corrected visual acuity before and after, you can see in decimal, that was before, so it's quite not a cataract, it's 0.6, and after the operation, it's quite 10-10. Sorry. the value of the spherical before and after, you see that we improve from 1.75 in absolute value to 0.40 after the operation. The cylinder was 0.8 diopter, and we reduced to 0.40. It's not enough. I think we still have to improve this value, and we still are ongoing to be better, because if you are not exactly on the target, the people are not very happy. And the uncorrected visual acuity far and near, I'm sorry I didn't have the intermediate because we didn't do a really good study. You can see that we have 0.6, the visual not corrected after the operation, and we are 0.8 for far. So it's a quite very good results, and the people are quite happy with these lenses. We have, for complication, it's not the complication with the lens, it's a rupture, a decentration, and rotation of the lens. Sometimes we are surprised when you do a toric Lucidis, you have sometimes a rotation. And we introduce the addon, which save our life. Really, it's really a good system to correct the lens. I will show you later. Very happy people, 38, happy 56, not satisfied 6%, and people who wore glasses all the time 8%. So I feel very good results to compare with multifocal lenses that we have before. It's really an easygoing lenses. You don't think about, you put the lens, and the people, you are quite 100% sure that the people will be happy after that. It's normal that you have to select your people. You have to have motivate, expectation, realistic expectation. We always say now less glasses, and we don't say that to the people no glasses. We operate both eyes very often on the both eyes in the same time. Good light for up close, and absence of strong myopia. When the people are not compliant, demanding too much, professional driver, hunter, all these people, we don't try at this time to put an EDOF lenses. We use a toric calculator from SAV, which is absolutely correct, and it's interesting. If you see your incision, you will see moving the lens, and we use for all the toric lenses the Barrett calculator. I will show you my joker, because when you are not exactly on the target with your Lucidis, the people are not perfectly happy. So we put on the bag, we put an add-on lenses from your country, and I love these lenses because you can correct the 0.75 or 0.5 with an astigmatism of minus 0.5, and then when you correct everything, the people are very happy, and that's doing exactly what the people are expected with just a little correction. And before that, we have done that with the LASIK and our PRK, and this lenses Sulcofix is absolutely perfect to correct the little acuity which is not exactly on the range. And we do that more and more often, and you can see the Lucidis is behind, and you can see this little central system. So the take-home message, the PNDB is the best of the EDOF. I'm really happy with this Lucidis. We use the Lucidis with a 2 mm incision now. At the beginning, it was a little difficult. No halo at all. And we use now the Lucidis toric when we have more than 0.75 dioptry. we use the baratory calculator, and we use an add-on as a joker when we are not in the target. And I'm finished, and I give you some photography from my family and from the Alps in Switzerland. Just start to come to do some tourists because we need you. Thank you very much.
Thanks a lot, Dr. Bovet. Thanks a lot. It was really, really interesting, and thanks a lot for those points. Before the time, we collect some questions over there. Just some highlights of what you just mentioned before. You pronounced the word of easygoing type of lens, and I think that's really it. This is what we get from feedback, is that if you tilt it up or if you decentrate a little bit, it's still much more tolerant to other lenses, especially that has rings on it, and that's one of the key things. The fact that you have this Aspheric in the middle, and then afterwards the platform of monofocal, you can even decentrate or tilt it up a little bit, and still you have a good result, which is not the case even for our addon, for example, which contain rings. That's very important as well. And another point you mentioned as well, and thanks for that, is the IP around that. So from you guys for India, we have this IP that was shown by Dr. Bovet. We have as well other patents, which it's really construct a type of IPs, if you would. So this PNDB that creates the EDOF is the sole property of SAV-IOL, and we get that technology. I mean, that's a very good point. Thanks for that. Any questions from the teams or from people? And thanks for the photography from Switzerland. We appreciate that. Because I mean, in Switzerland today,
there is a question just now: is the pupil dependent upon how much pupillary diameter minimum is allowed?
It's
stop sharing your screen.
Yeah, Professor.
It's written that more than 2 millimeters, it's decrease the system for near. But in the real life, it's really not like this. We say to the patient to have a good light, and but it's really an easygoing lenses. And I will say for the old people, they have always a little pupil, and so they are not very unhappy with during night. They can still read something. It's astonishing because this Lucidis was not at all what we expect. The lens gives us quite more than we expect, I will say.
Absolutely.
Any other questions?
And even I will add, we put this lens to young people now because with a big pupil, they still have a good reading system. Even the pupil is big. That's astonishing. That's really something you can put that in a young people like 40 years old or 30 years old, and you will be astonished the good results you have, better than a multifocal. Definitely.
Can I ask a question?
Yeah, sure.
Can I ask a question to Dr. Bovet? I just want to know why the platform is hydrophilic platform, because then you know that makes it more difficult for us to use it for youngsters. Is there any particular reason why it's a hydrophilic platform and not a hydrophobic platform?
You have to ask.
Well, you want to answer, or you want me to answer the question? Either way, I can answer that. I mean, we have started working on the hydrophilic because it's much more easier from an R&D perspective to fine-tune what we want to do. I would say that today we are really manufacturing on hydrophilic. Nothing prevents us in the future to do the same thing in hydrophobic, although we have not tested that, if you would. So from a design perspective, again, from a manufacturing ability, that was the starting point. That's the explanation. Nothing prevents us to do that in the future.
Thank you. Okay. So we move on to the next speaker. I believe Dr. Max, you could invite Professor Dr. Russo.
Just before that, Dr. Kenya, we have just a kind of a last question, very quick, to Dr. Bovet. The question is, do you recommend PRK for those having surgical induced astigmatism?
Before we have done that, but now we use addon sulcofix from eye care, and we find that that saves the problem. It's quite better than a PRK. It's easy to use, and we are on the target quite easier. I remember an old lady. I've done, I think, 3 or 4 PRK because the eye move after the operation of cataract. You have a moving of the astigmatism, and I don't know why it's not the cornea is not so good. And I recommend really an addon. And the addon, after that, the people are happy, and we don't have any problem. And we do a correction of 0.5 at 10 degrees, for example. And it's work.
There's a question from Dr. Ahmed that some surgeons complain that while injecting the lens, the haptic enters upside down.
Yeah, you have to be careful at the beginning when you inject the lens. It's quite a hard lens to inject. You have to be careful not to inject with strong and soft. You have to be very smooth, and you can return the lens, but it's quite a stiff lens. So you have to do that in the right manner. And for the toric lenses, sometimes you have to turn all the time in the same manner, in the
Clockwise.
Clockwise, yeah, exactly. If you don't do that, you will be in trouble.
Thank you, sir. I think Dr. Ahmed, that answers your question. There's one more question from Dr. Malkan. He asks whether this lens is advisable if the patient has a large angle kappa.
That's a very good question. I never measure that, but I will be worried about if you have a very big angle kappa, perhaps the lens will not perfectly well working, but it's quite seldom. I was surprised when we have trouble with the capsule. If we are not exactly center, like Max say, it's still working. The people are not completely happy, but we can continue to work. And at this time, we do really very fast the second eye. And if you do the second eyes, then you have a compensation with both eyes. It's really 2 eyes friendly. And I will say, no, we do with this, the people who ask for the Lucidis, we do both eyes in the same time. It's better.
Thank you, sir. So one more thing I noticed was that you said that you put the CTR ring in all patients now because it helps with the centration. So in every surgery that you do you put in a CTR ring?
Quite in a, I will say yes. Sometimes the insurance doesn't like that we put a CTR ring. It's only a cost problem. But if I can do, I will do it, because each time you have a toric lenses, it's the lens is really, it cannot move again. And you see, you have two dimensions of the Lucidis. We always use the little one, and sometimes when you have a big capsule, you can turn around. We
Yes,
have one patient who was turned, and so I put a second capsule ring.
Yes, sir. Very good advice, sir. Very good advice. Thank you so much, sir.